You received your blood test results, opened a PDF on your phone, and suddenly felt that chill down your spine when you saw your LDL highlighted in red above the reference range. For most people, that's the moment panic sets in. Conventional medicine has taught us for decades that high LDL is an automatic silent killer, a ticking time bomb that will clog your arteries at any moment. But the most recent science in cutting-edge clinical practice reveals something far deeper and more complex than a simple number on a piece of paper. The truth that few medical offices reveal is that high LDL by itself is not a diagnosis of disease. There is a specific group of people for whom elevated LDL can be perfectly harmless, and in some contexts, even a sign of an extremely efficient metabolism. On the other hand, there are thousands of patients who die of heart attacks every year with LDL levels strictly within target. Today, I'm going to give you the definitive answer you've been looking for. When your high LDL is truly a real danger to your heart, and when it's just a number misinterpreted by outdated medicine. Hello, I'm Dr. Harrison Blake. I'm a physician with 15 years of clinical experience dedicated to understanding cardiovascular health beyond surface appearances. If you want to stop being a prisoner of isolated numbers and truly understand how your body works, go ahead and like this video, subscribe to the channel, and turn on notifications. Comment below, what was your last LDL value, and what guidance did your doctor give you? I want to hear your story. Before we judge LDL as a criminal, we need to understand its noble function. The first major mistake is calling LDL cholesterol. LDL is not cholesterol. It's a low-density lipoprotein. Imagine your body as a complex network of cities, and your bloodstream as a highway system. Cholesterol and fats, triglycerides, are passengers that need to reach different destinations. But they have a problem. They're fatty and blood is made of water. Since fat and water don't mix, your liver has to build special containers to transport these passengers. LDL is essentially that container. Your body spends an enormous amount of energy producing LDL every single day because it is a logistics delivery system of life. It leaves the liver loaded with vital nutrients. First, it transports cholesterol itself, which is a basic raw material for building the membranes of all your cells. Without LDL delivering the bricks and cement, your body couldn't repair even a simple scratch or renew tissues. In addition, LDL carries essential fat-soluble vitamins, such as vitamins A, D, E, and K, along with powerful antioxidants like coenzyme Q10. Another crucial role of LDL is energy transport. It delivers triglycerides to your muscles so you can walk, run, and move when you're on a lower carbohydrate diet. Your body depends even more on this fat transport system to keep the engine running. If LDL were inherently evil, human evolution would have eliminated this process thousands of years ago. Your body is not designed to kill you by default. The system is built for survival and constant repair. The issue medicine focuses on is what happens when this container stays on the highway too long, without unloading, or when it gets damaged. But in a healthy, metabolically flexible body, LDL completes its route, delivers its cargo to cells with receptors for it, and returns to the liver to be recycled. Understanding that LDL is a vital transport vessel is the first step toward no longer fearing it. The risk is not in the existence of the transporter, but in what happens to it when the highway environment, your blood, becomes toxic. The question, is high LDL dangerous? Can only be answered if we analyze the state of the particle. In cutting-edge medicine, we know that native LDL, the kind that has just left the liver, is harmless. For it to become bad LDL, it must undergo a chemical modification that makes it unrecognizable to your cells. The two main processes that cause this are glycation and oxidation. Imagine LDL as a brand new metal container. Glycation is like pouring sticky syrup all over it, and oxidation is like it's starting to rust. Glycation occurs when you have elevated blood sugar levels. Excess glucose binds to the proteins on the LDL particle, deforming its structure. Once deformed, LDL can no longer fit properly into the receptors of the cells that need it. It ends up wandering in the bloodstream much longer, increasing the likelihood of undergoing the second process, oxidation. When LDL oxidizes, it changes its electrical charge and becomes toxic to the endothelium, the inner lining of your arteries. At that point, your immune system steps in, Because the LDL now looks like an invader or rusted debris, immune cells called macrophages try to eat these particles to clean the blood. The problem is that these macrophages become overloaded with oxidized fat, eventually die, and turn into foam cells. These dead, inflamed cells form the core of the atherosclerotic plaque that clogs arteries. So the danger is not high LDL itself. It's oxidized LDL. If your LDL is 180 but your blood sugar is controlled, you don't smoke, and you consume healthy fats that protect cell membranes, your particles remain native and safe. However, if your LDL is only 90, but you live on ultra-processed foods, inflammatory vegetable oils, and constantly elevated insulin, that small amount of LDL will be highly oxidized and dangerous. The medical answer to whether LDL is dangerous is, it depends on the terrain. LDL does not jump into your artery wall on its own. It is pushed there by inflammation and oxidation. The real criminal is not the container, but the corrosive environment it is forced to circulate in. Looking only at the total LDL value is like trying to predict a traffic accident by counting how many trucks are on the road, without checking whether the drivers are intoxicated or the road is full of potholes and oil. In recent years, a phenomenon has left doctors and laboratories stunned. It involves a specific group of people known as lean mass hyperresponders, or LMHRs. These are typically athletic individuals with low body fat who adopt a ketogenic or low-carbohydrate diet to improve performance or metabolic health. Their lab results are shocking. While triglycerides drop to excellent levels and HDL, the good cholesterol, rises dramatically, LDL skyrockets, crossing 200, 300, and in some cases even 500 milligrams per deciliter. Under old guidelines, these individuals should be having heart attacks in the lab waiting room. Yet, what we observe in clinical practice and recent research is that many of these patients show impeccable cardiovascular health markers. Why does this happen? The answer lies in what's called the lipid energy model. When carbohydrates are removed, your body stops using glucose as its primary fuel and switches to fat. To deliver that fat to your muscles and organs, the liver needs more transport trucks. Because the individual is lean, they don't have large stored fat reserves to release slowly. They require rapid and dynamic lipoprotein traffic. In this context, elevated LDL is not a sign of disease, but a reflection of a high-performance logistics system delivering energy. Here, LDL acts as dynamic fuel, not stagnant waste. These individuals often present what's known as the LMHR triad: high LDL, high HDL, often above 80, and low triglycerides, often below 70. When we examine their arteries through imaging studies, such as a coronary artery calcium score, which we'll discuss shortly, we frequently find completely clean arteries, with no evidence of plaque despite sky-high LDL. This teaches us a valuable lesson. The human body is adaptable. High LDL in someone who smokes, is sedentary, and has diabetes is one thing. High LDL in a metabolically healthy athlete who primarily burns fat for fuel is a completely different biological reality. Treating both patients the same way, based solely on LDL levels, is not just lazy medicine. It's a serious technical error. The question should not be, how high is your LDL? But rather, what does your body do with that LDL when you look at your lab report and see LDL-C? That C stand for cholesterol. The lab is measuring the total weight of cholesterol carried by LDL particles. But imagine you want to assess the risk of traffic congestion on a highway. What matters more, the total weight of cargo the trucks are carrying or the number of trucks on the road? Obviously, the number of trucks. In modern medicine, the marker that counts these trucks is a lipoprotein B or ApoB. Each LDL particle contains exactly one ApoB molecule. Measuring ApoB is therefore the most accurate way to determine how many potentially atherogenic particles are circulating in your blood. Why does this matter? Because you can have a low LDL-C, low cholesterol weight. But if that cholesterol is distributed among thousands of small, dense particles, your heart attack risk is extremely high. These tiny particles are dangerous because they penetrate the arterial wall much more easily than large, fluffy particles. This is where many doctors and patients are misled. A patient with diabetes or insulin resistance often has LDL within target, say 90 milligrams per deciliter, but their ApoB is very high. That's because their body is producing an army of small particles that the standard test cannot differentiate. Meanwhile, the lean mass hyperresponder may have an LDL of 200 but a proportionally lower ApoB, indicating large, energy-rich, relatively harmless particles. Beyond ApoB, we can also request LDL particle fractionation to assess size. If your profile is pattern A, you have large, fat-rich particles that are unlikely to form plaque. If it's pattern B, you're at higher risk because you have small particles that oxidize quickly. If your doctor still makes decisions based only on cholesterol weight, without considering ApoB or particle pattern, they're using 1970s technology to treat a 21st century patient. Real medical answers require depth. Don't tell me how much your cholesterol weighs. Tell me how many particles you have and how large they are. Only with ApoB can we begin to discuss true risk or true safety. Too often, medicine gets lost in statistical probabilities drawn from blood tests. But blood is just a fluid passing through. Heart disease happens in the artery wall. That's why, in my 15 years of clinical practice, I rarely make aggressive decisions based solely on LDL without first ordering a coronary artery calcium, CAC, score. This is the ultimate test. A quick, non-contrast CT scan that detects calcium in the heart's arteries. Why calcium? Because calcium is the scar of a plaque that is inflamed and hardened. If your LDL is 190 but your CAC score is 0, it means that despite high circulating LDL, it is not penetrating your arteries, not oxidizing, and not forming plaque. A 0 score in someone with high LDL completely changes the prognosis. The risk of a cardiac event over the next 10 years is statistically very low, often lower than someone with low LDL, but a positive calcium score. We also have carotid ultrasound with intermediate thickness, CIMT measurement. This test allows us to see the age of your arteries and detect thickening or soft plaque that hasn't yet calcified. It's a direct window into your circulatory system. If your carotid arteries are clean and smooth like those of a 20-year-old, why panic over an LDL of 160? The major mistake in modern medicine is treating theoretical risk instead of established disease. It's like being fined for speeding just because you own a powerful car, your high LDL. Even if you've never exceeded the speed limit, your arteries are clean. CAC scoring and ultrasound show whether you've actually been speeding and caused damage. For patients with elevated LDL, especially lean mass hyperresponders, these imaging tests provide peace of mind. They allow doctor and patient to decide safely whether medication is necessary or whether lifestyle alone is protecting the system. Remember, LDL is a risk factor, but plaque is a disease. Never accept lifelong treatment based solely on a blood estimate if you can have a real image of your heart in your hands. Technology exists to give us certainty, not just guesses based on population averages. The definitive medical answer about LDL risk depends almost entirely on two other numbers already on your lab report, but often ignored: triglycerides and HDL. Together with LDL, they form the lipid panel. But the real insight lies in the relationship between them. In a healthy body, triglycerides should be low and HDL should be high. When you have that combination, your LDL, regardless of the value, tend to consist of large, safe particles. The golden rule is to look at the triglyceride to HDL ratio. Divide your triglycerides by your HDL. If the result is under 2, ideally close to 1, that's a strong sign of insulin sensitivity and harmless LDL. For example, if your LDL is 200 but your triglycerides are 60 and your HDL is 80, your ratio is 0.75. That's the classic healthy hyperresponder profile. Cardiac risk here is minimal because the metabolic environment is clean. On the other hand, if your LDL is low, say 100, but your triglycerides are 200 and your HDL is 30, your ratio is 6.6. That indicates metabolic catastrophe. Your LDL particles are small, dense, and highly inflammatory. So never look at LDL as a solo player. It's part of a team. If triglycerides and HDL are in ideal ranges, high LDL may simply reflect efficient energy transport. Metabolic context is what separates a protected heart from a heart at risk. The definitive medical answer to the question, is high LDL always dangerous? Is a clear and resounding no. As we've seen, LDL is a vital transport particle. Its isolated value on a blood test is incomplete and often misleading. The real danger lies not in the number, but in particle oxidation, total ApoB count, and above all, metabolic inflammation. If your arteries are clean, your blood sugar is controlled, and your triglyceride to LDL ratio is low, high LDL may simply be a sign of a body that has learned to burn fat efficiently. I'm Dr. Harrison Blake, and my goal is for you to leave this video with the clarity you need to stop being held hostage by outdated protocols. If this content gave you the peace of mind you were looking for, share it with someone who lives in fear of their lab results. Don't forget to like and subscribe. Take care of your biological terrain, and your heart will thank you. See you next time.